Hello and welcome to the 2012 San Antonio Breast Cancer Symposium. My name is Skip Burris and I'm from the Sarah Cannon Research Institute in Nashville, Tennessee. I'd like to introduce you to Bill Gradishar from Northwestern and Hope Rugo from the University of California, San Francisco, and we'd like to discuss with you some of the highlights from the meeting here in San Antonio. There was a presentation today that talked about the prevalence of PI3K mutations in patients that had hormone-positive breast cancer, in particular progesterone receptor positivity, and I think that's a fact that we're becoming aware more of. Whether that number is 20, 30, or 40% depends on the subgroups, but the Bolero-2 data last year showed the positive results for Everolimus together with exemestane. Bill, how often are you going to dual pathway blockade, and when do you decide to make that decision in your ER-positive patients?
Well, I think the Bolero-2 data was fairly influential. I think in patients who've progressed on an AI where they, in our view, are still endocrine candidates, and perhaps for whatever reason fulvestrant is not the option you want to choose, then I would certainly partner an AI with an mTOR inhibitor. And of course, even with fulvestrant, there are now trials going forward looking at whether or not partnering fulvestrant with an mTOR inhibitor might confer a similar benefit. But I think beyond first progression on an AI, and if a patient were an endocrine candidate, I would think about adding Everolimus.
I hope, have you done that common in your practice, and or do you ever profile those patients to help make the decision?
Well, I was a big participant in the Bolero trial, so Bolero-2, so I have treated quite a number of patients with Everolimus or placebo. And now we're conducting a trial looking at an mTOR inhibitor with or without an inhibitor of IGFR, the insulin-like growth factor receptor, actually a very active combination. So I have used it, and I was already pleased with the combination results in the blinded trial because the toxicity makes blinding quite difficult.
Right.
But still, I think the results from Bolero-2 were quite impressive. The biggest issue for these patients is you're taking them from taking a pill with some joint aching and hot flashes to having real toxicity, bigger toxicity. So we've been working on ways to try and better educate patients to actually potentially publish a paper altogether because, of course, you participated in the trial as well and have a lot of data yourself on this combination. But ways to try and better educate patients and control toxicity. I know some people have been using steroid mouthwashes with some anecdotal reports of benefit. So. We'll see. But in patients who aren't eligible for the trials that we have been giving Everolimus. I think we're going to have to, as we move forward, really try and understand who benefits. Bolero-2 unfortunately just didn't provide us with that information, but as you know, there are correlative studies that are planned, and maybe we'll see some results next year. I don't know.
Right.
Certainly PI3 kinase, which is present in the majority of patients with breast cancer, PI3 kinase mutations, is not the indicator of sensitivity to these agents.
Right. Yeah. Very interesting.
Are you using it frequently in your practice?
We are. We actually, I think in line with what you and Bill both commented on, to me, I think that it's been difficult to predict who'll have the substantial toxicity. That tends to be 10% of patients or so. The majority of patients tend to do well with it, and dose modifications have been relatively easy to do. But, in terms of making the decision whether to switch to chemo or add on Everolimus, the choice has been to add on Everolimus.
Yeah, same with us.
Yeah.
I think a couple of things are worth just briefly mentioning. A trial that was presented by Finn looking at letrozole with or without a cyclin-dependent kinase inhibitor, a drug that inhibits CDK4 and 6, which is, they don't all inhibit the same cyclin. They don't all inhibit the same kinases, so it's important for those of us who aren't doing that laboratory research to keep it in mind. But anyway, this is a CDK inhibitor of 4/6, and they did a randomized phase 2 trial, actually 2 steps in women who had untreated, in the metastatic setting, untreated ER-positive disease, letrozole with or without the cyclin-dependent kinase inhibitor, which has a whole bunch of numbers. And their initial results suggested a significant prolongation of progression-free survival, and they presented some updated data, which again shows very encouraging data with this combination. So they've planned a multi-center phase 3 trial, which should be opening early next year, and we're participating in that trial. It's going to be very interesting to see what happens with that combination, because really a differentiation different way of approaching hormone resistance, and also in the first-line setting. Of course, we're still waiting for some data about anti-angiogenic agents, some of which will be presented at this meeting too.
I'd echo your comments about the CDK inhibitors. They aren't all the same. There's been a variety through the years, and the CDK4/6 platform, several major pharmaceutical companies, several biotech companies with molecules that look particularly active. So I think we'll see more about that in the next few years.
Thank you.
There were some a few interesting presentations, not to talk about in detail, but they were talking about sort of intensifying anthracycline use. And one of the things that always concerns me, it's a longer term follow-up of these trials, is that there is an increased risk of secondary leukemias. And we saw that in the sort of intensive metronomic study that was presented not at this year, but last year's ASCO as well. So, you get more toxicity, you may get a little more benefit, but you're balancing that against this higher risk of secondary leukemias. And actually, the collaborative group working with the NCCN breast cancer database reported data today on the risk of myelodysplasia and secondary leukemia, and it was quite low. I mean, less than 0.3%, as we've seen previously with current regimens. So it's sort of a lesson to think back and say, okay, anthracyclines aren't all bad. I mean, this is a small percentage, but it's important, and we should be thinking about it when we're testing more aggressive regimens.
Right. Do you find yourself giving anthracyclines for just triple negative patients? Do you find yourself giving it with trastuzumab sequentially for patients? What type of profile gets an anthracycline in your practice?
Well, for triple negative breast cancer, I'm not sure I know any better than anyone else at the present time how to treat those patients. So I think where we use anthracyclines is typically in the adjuvant setting. Typical ACT-like regimens. An ACTH regimen is appropriate for HER2-positive disease. We've diminished our use of anthracyclines over time, not so much because of the myelodysplasia or those concerns, but if we can avoid cardiac toxicity, we do.
Yeah, I find myself that it's that nebulous bad tumor, a little young, a little aggressive, the pathology report will sway me to go to an AC followed by T-type regimen.
I have, looked at the Jones data, which, we use a lot of TC for, earlier stage cancers, ER positive, but they have a high enough risk that we want to give chemo. But for triple negative disease, there were like 100 and something odd patients in triple negative disease in that trial. It's just not enough data to make me change to not using our standard ACT type approach. And then I was interested, I did a sort of cyber tumor board recently on a 65-year-old without cardiac risk factors with node positive, HER2 positive disease, ER positive. And every single person I asked wanted to give her ACTH, not TCH. So it is interesting. I think there's a geographic variation, but there's still a lot of use of ACTH going on, and it's got to be just individualized to the patient. There was a couple of other studies I think worth mentioning. There was a randomized phase 3 trial that looked at capecitabine versus eribulin. And that trial was, their hypothesis was that eribulin would result in better outcome, and it didn't. It was very similar. And part of that really has to do with toxicity issues, that capecitabine can be given even with the toxicity that we all see reasonably easily in most patients. And if you have a big group of ER positive patients, they can stay on it for a long time. But eribulin, the issue with eribulin at day 1, day 8, every 3 weeks at 1.4 milligrams per meter squared is bone marrow toxicity. And some of these patients just really get very significant cytopenias. So as we learn better how to use eribulin, it may be a little bit different. It was as effective. I mean, it's not like a worse drug, but certainly it wasn't better. And then a study that I think is really, really important that looked at neurocognitive impact in adjuvant chemotherapy. And this was a combined study with Michigan and people in Toronto very interested in cognitive function. We have an ongoing prospective trial, and this is really big interest. And they looked at functional imaging with MRI and also cognition. What was interesting was they have confirmed data previously suggested in other trials that really the neurocognitive performance is worse before you start treatment even than you would expect compared to norms, and that you can see changes in MRI different from what you would expect. I mean, one of the questions always is that anesthesia or anxiety or what? But the patients who had that finding before treatment actually had more fatigue and fatigue correlated with more neurocognitive defects over time, and those patients presumably also take longer to recover. So I think what it tells us is that if we had some quick screens where we could predict to those patients who have some problems before starting treatment, we could potentially offer them more support during therapy. I mean, the support could come from a variety of different ways, but certainly looking out for fatigue, trying to manage fatigue, and also doing some kind of cognitive skill training might be beneficial in those patients.
Yeah, I would agree. I mean, I think there is that element of feeling like you're going crazy you hear from the patients, and the forgetfulness and the fatigue and just the consternation around that. So I think more data, shining the light on the problem, and just making it aware that it is a reality really will help patients.
Yeah.
Bill, any final comments before we close?
No, I think these are all related to survivorship issues, and they bear an importance not only to patients but their families and how patients will do in the long term. So I think we have to have a focus not only on clinical outcomes regarding the tumor, but how patients function long term.
Thank you very much. I appreciate you spending some time with us.
Thank you.